All right, our next talk is the question I just asked, the vessel prepping. I think it's very relevant to what we are actually seeing in the live case right now, and it's by Fanelli Fabrizio. He's the director for the vascular and IR department in Carnegie University Hospital, Florence.
Thank you. It's definitely a great pleasure for me to be again on this podium, and I would like to thank PK and the organizer for the kind invitation. So these are my disclosures. Regarding vessel prep, I think that nowadays everyone is familiar with, and we are using more and more frequently in our daily practice since many couple of years. Not only in combination for drug-eluting devices, balloons or stents, but also when we just deploy a bare metal stent or we have to complete the procedure. There are several advantages that are correlated to the vessel preparation. First of all, we can increase the lumen of the vessel. We can have a more stable situation, reducing the possibility of elastic recoil. And also, we can also prepare the vessel for a better vessel scaffolding. At the end of the story, there is also a better transfer of the drug from the device to the arterial surface, and we can reduce tremendously the rate of flow limiting dissection and as well of bailout stenting. The question that is still open when to do a vessel preparation, because nowadays we are still convinced that we have to use it in more complex situations. This means CTO or in-stent restenosis, or when there is a lot of calcium within the vessel. Calcium, we know, is the big enemy for all the endovascular procedures. You know that calcification can be placed in the intima or in the media. There are different strategies to work on the calcium, especially because if we perform a very nice vessel preparation, we can have a better controlled dissection. You know that dissection is related to any dilatation of a calcified plaque. But what we have to avoid is it's a huge dissection, a flow-limiting dissection that is an uncontrolled situation that many times occur, especially when we perform a pretty aggressive dilatation. How we can perform the vessel preparation? In my opinion, there are two big families. There is the debulking or plaque removal. These are the different types of atherectomy available in the market, plus laser. Or we can modify the plaque. This could be done using a standard PTA balloon, but also we have a cutting balloon, scoring balloons, and what we consider non-conventional or low traumatic balloons. Or we can use other devices like IVL or the Flex system. This is a very interesting paper that was published a couple of months ago, because we know that also the standard angioplasty can be considered a method for a vessel prep. They perform a retrospective evaluation on 97 patients, more than 100 lesions. All the lesions were evaluated with IVUS, and all of them were very calcified with a 360 degrees of calcification in the circumferential space, so with a mean lesion length of 20 centimeters. What came out from this study is that there is a direct relation between the efficacy of the vessel preparation and the size of the balloon. This is something important because also in my practice, generally we use an undersized balloon at the beginning just to prepare the vessel and avoid dissection. But according to them, you can see from the scheme that if you're using something larger, 2 or 3 millimeters more than vessel nominal diameter, you can achieve a better outcome. Obviously, when we increase the size of the balloon, especially in this kind of lesion, there is a higher risk of complication. Another option is to use some special balloon. This is the chocolate balloon that I think you are familiar with. These are the data regarding a single center retrospective study, more than 100 patients, where predilation 1-to-1 ratio was performed in 48 patients using the chocolate plus a DCB, and in 63 patients by a standard balloon plus DCB. What came out was very interesting because you can see here that regarding severe dissection and bailout stenting, there was a terrific difference between the chocolate balloon and the standard balloon with a very low rate. And also, chocolate balloon in combination with DCB performed better in terms of primary parency, 6 months, and freedom from TLR. Another balloon available recently is the Serenator. This is presents a special technical aspect with some linear stripes on the surface of balloon. The goal is to achieve a nice dilatation, reducing the possibility of dissection. And also, this balloon presents the feature that you can dilate it at very low pressure that reduce the possibility of a stress of the plaque and then the dissection again. So these are some beautiful images from OCT and IVUS evaluation. You can see here the fracture in the plaque with another A-grade dissection within the lesion. Some data supporting the use of the Serenator. There is the Prelude study above and below the knee. Above, you can see the rate of bailout stenting was very low, 4%. And then there is a very interesting study. There is a preclinical data using to evaluate the drug uptake. This is in animals. They did in one leg the combination of a standard balloon plus the impact admiral DCB, and in the other side was the Serenator for the preparation of the vessel plus DCB. And you can see that using the Serenator, there was 3 times a higher dose of drug within the tissue. So this improved the amount of drug that we are able to transfer to the arterial wall, so to prevent intima hyperplasia. Another option is obviously atherectomy. I think you are more familiar with me with this kind of device. We have a lot of data supporting the use of atherectomy plus DCB, not only rotational, but also hybrid or the atherectomy. This is a simple case that we did in our lab. You see an instant stenosis, pretty long, more than 30 centimeter. Angel showed the complete occlusion of the stent from the origin of the SFA down to the pop segment. We did the preparation using the Phoenix atherectomy device, and then we complete the procedure with a drug-coated balloon. And this is the final Angel. You can see from the IVUS there was no material within the stent, so we were able to remove all the material within the lumen. And very nicely, we have a 3 years follow-up with a nice ABI, a couple of millimeters of material within the stent, but still a very nice patent lumen. Another option is IVL. I think you are familiar with this device. It is getting more and more popular. We have a very important data supporting the use of IVL in combination with DCB. You can see better outcome in terms of primary patency if you compare to standard balloon plus DCB again. Very recently, a new device came into the market. This is the Flex system. This is not a balloon. It's not an atherectomy. It's a different device. This is based on a different technology. There are 4 stripes that are able to adapt the caliber to the arterial diameter, and they create some control depth micro incision within the plaque. This is something very interesting because it can reduce the possibility of dissection and at the same time increase also the drug uptake. These are the images from OCT. You can see nicely what is coming into the plaque, the modification in the morphology of the plaque. And also we have some nice data coming from several studies where the Flex system have been used in preparation in complex setting. However, this device nowadays is not supported to be used in heavily or severe calcified lesions. So in conclusion, we can affirm that vessel prep can be considered nowadays a must, especially when we use DCB and DS, but also in preparation of a drug-eluting of a cover stent or like the superior stent. There are a lot of technologies available. Obviously, we don't know exactly which could be the best to use because, unfortunately, comparative studies are not available and also are very difficult to manage and to bring on. Atherectomy is still the only method that is allowed to debulk the plaque, but we know that we look forward to a combination of new devices in the near future. Thank you for your attention.